Hello. First of all, thank you all for listening to us today. My name is Tyler Sandlin. I'm a pediatric provider, APRN at the Children's Clinic here in Batesville. I have 12 years of experience within pediatric intensive care unit and outpatient medicine. The first 8 of those were at Arkansas Children's Hospital, the last 3 years of my career being in my hometown here. I come to you today in hopes that you will believe my message and believe the statistics. If you do not believe medicine, that you will believe what I'm telling you as a person. I have grave worry in the next weeks regarding the SARS novel coronavirus, not just in our adult population, but quite frankly, I'm mortified at the trends that we are seeing in our pediatric population. When we discuss COVID as we know it in totality, many things have changed. For the first 14 to 15 months, evidence-based literature, and even in our clinic, we found mild to moderate disease and virus found more often than not children are asymptomatic vectors of the virus and would spread it amongst family members. In recent months, evidence-based literature began to report this virus mutations and variations among the viral disease. We began reading of increased virulence and severity of the infections with pediatric populations. Within the last 4 weeks, we have now seen this viral shift within our own children's clinic here in Batesville, Arkansas. I have cases ranging from high fevers, cough, congestion, accelerating to acute respiratory distress, and some kids with complications with COVID, known as MISC. All within my own practice, our clinic with much more of these situations. I can stand here to tell you that the myth that our young children are not affected by COVID is absolutely false. I have been asking in recent weeks if adolescents may be more predominantly affected by this virus. I can say that I have a child from our clinic under 6 months of age requiring mechanical ventilation, and this virus is not spared discriminating against our toddler groups. In our state, roughly 18% of our COVID-19 cases are related to individuals 18 and younger. Children 11 and under make up 11.2% of active COVID-19 cases. I'm particularly worried for this age group for their inability to obtain a vaccine at this time. One may ask how this compares to August of last year, in which I would respond less than 2% of individuals under 18 accounted for active cases in 2020. Things have changed. Unfortunately, our availability of inpatient services now are limited. Surging RSV cases have set a strain on pediatric hospitalizations as of recent. This, in combination with new pediatric COVID surge, has made inpatient service scarce. COVID hospitalizations in our children under 12 from 2021 of April to July have increased by 463%. We have seen a 275% increase in pediatric intensive care needs from April to July of this year. Our state has seen a 689% increase in COVID cases in those under 12 years of age. In fact, we have more hospitalizations this month in the month of July than in under 18 years from all other times during the COVID pandemic as we know it. I do not know exactly what to do, but I do know we must act somehow. We all know how important education is to our children. We need school, no doubt. In fact, the American Academy of Pediatrics notes the importance of us taking precautions in order to keep our children safe at this time. Distancing masking can do this, but I understand that in the school setting, distancing is not always possible. This is what makes masking all so much more valuable. Dr. Cam Patterson, Chancellor of UAMS, recently stated the only safe way for our children to go to school and re-enter school setting was through precautions and masking. Masking recommendations for schools have been outlined by the American Academy of Pediatrics and by the American Academy of Family Physicians. I don't have the answers, however, I tell you that science tells us masks work. In fact, in our own practice, the effectiveness of masking was shown crushing through RSV and flu this last winter season. In May, school ended. We saw viral disease surging from common colds, RSV, and typically lie dormant during the summer. But now we're seeing these viruses throughout our summer months. My fellow providers and I, as of recent, have been making contingency plans by the day where we may send our pediatric patients and inpatients if service may require. A situation we never thought would occur, and I can say one patient I have personally searched within the last days and found pediatric inpatient service outside of our state. Arkansas Children's Hospital at this time is only accepting level 4 admissions. They can help and they try as they can, but their availability is limited. I have friends working there that describe a situation in which I can honestly say needs our prayers. Like other situations, space, staff, and resources are limited due to this dreadful virus. Many who know me have heard me say it doesn't have to be this way. See, in medicine, we have been struggling to make do with a new virus that's taken us by storm. Unfortunately, it has become a political chess game. For those who know me know that I don't like politics, and politics don't belong in science and medicine. This year medicine has taken the brunt of the jokes, if you will. We see the horrors of what the COVID virus does, and the COVID virus, what it looks like in the COVID unit within. The lives lost and affected. Yet we leave work and hear people mocking the virus and negating the validity of what we're seeing. Like many others in medicine, I have lost friends. My family chastised for my work, for simply telling individuals what science has shown me in regards to the virus and attempting to present sickness in our patients and community alike. But we push on in medicine despite the heckling. Because a long time ago, my father told me, son, above all things, do what is right. You have to stand for something in life even when it may not be popular. And I believe it. And believe it or not, I can relate to what you're facing right now. Leadership roles are not easy. But to be leaders, we must act in a way to protect our flock, even with outliers. Please help us mitigate infection. We do not have the capacity to hospitalize our children's needs at this time. I cannot fathom or picture what this may look like as school begins. In the coming days, pediatric beds will be short, whether that be newborns in need of NICU service or RSV admissions, not just COVID cases. Please help us. Let's not be the school on the news, failing to implement methods of mitigation with flocks of children and teachers infected and quarantined. Let's be known as a school that had a plan, which limped us through the coming weeks and never went virtual. Something we can be proud of. I'm telling you today, the coming weeks will be brutal. We have not seen bad days. Let's do this for our children, I'm begging you. We've got this. Thank you for your time.
Hi, I'm Dr. Amanda Smith, a local pediatrician here at White River Medical Center. Whenever I chose a career in medicine, I knew it was going to be a difficult path, but nothing could have prepared us for how difficult everything has been the past couple of years. Sure, my colleagues would agree that nobody went into medicine expecting to have to deal with a national pandemic. And the past few months have especially been hard for our pediatric population. We have seen a great increase in our hospitalization rates and complications with this new Delta variant of COVID. Most recent data that we've seen from Arkansas Children's showed since April we've had over a 500% increase in pediatric cases and almost a 300% increase in pediatric hospitalizations. So with that being said, the most important thing that we can do to help prevent the spread of COVID is encourage a masking policy. Studies have shown time and again that masking helps prevent the spread of coronavirus, especially in our more vulnerable populations, such as our pediatric populations and our immunocompromised. I think it's important to be one of the schools at the forefront, and as a school who is being proactive in helping prevent spread of the coronavirus and not a school that is being reactive, because once one person becomes infected, it's incredibly difficult to control the spread of the virus. With a masking policy, we can help keep our students safe and help keep our doors open longer so that the students can reap benefits of not only the educational system, but also the social and emotional benefits that our public schools provide. Because we know as pediatricians that our local schools provide so much more than just education. Thank you.
Hi, I'm Dr. Melody Moody from the Children's Clinic at White River Medical Center in Batesville. Today I've been asked to speak with you about the coronavirus. Within our local communities, the state and the nation, there's been a lot of debate recently, some healthy and some dangerous, concerning the best way forward to take care of our kids. I think part of the difficulty has been with the changing recommendations and with the understanding of what science is. Science is the study of how things work, how our bodies work, how our children's bodies work, how viruses work, and how we can best treat them. Because of this, as we've learned new things, the recommendations have shifted. Coronavirus is not new, though. We've had a coronavirus problem in pediatrics for some time that was basically the common cold and even a flu-like issue. It was difficult for some kids, but for most they did well. We've also had variants of coronavirus that have caused problems in the world. SARS, which was the severe acute respiratory syndrome of 2003, and then MERS, the Middle Eastern respiratory syndrome, caused a lot of death and difficulties. It was only a matter of time before these viruses would mutate and cause problems again. And now we have the coronavirus SARS-CoV-2 problem with COVID-19. To understand about this, we need to know about a virus. A virus like coronavirus is made of RNA. The RNA enters our cells by the spike protein on its cover that connects with the ACE2 receptor on our cells. When the cell accepts and receives this virus, the virus makes new plans for the cells to replicate itself. Lots of viruses produced and spread out into the world, into our bodies, to infect others and cause damage. Some of the message within the viral RNA tells our cells also to hyperreact, a hyperinflammatory response, which causes a lot of the illness and death from COVID. When the virus goes into our cells and makes new copies, replicates, it sometimes makes mistakes. Sometimes these mistakes make the new variant less of a problem for our bodies to manage. Sometimes it makes no difference whatsoever, but unfortunately we have a case where the Delta variant has made it more dangerous. There's actually 2 changes on the spike protein caused by the Delta variant, which make it more sticky for our cells, more likely to be introduced into our cells and to take over and make more virus. Because of this increased viral load and a change in the symptoms, it's now more concerning for our children. There's only a couple of ways that we as physicians can help right now to prevent this from spreading to more children. One is masks. When the virus is spread out into the world, either aerosolized or in air droplets, masks help. They are not a perfect solution, but they do diminish the chances that we will contract the illness. The other is vaccines. Vaccines are aimed at this point at that spike protein to decrease where the virus attaches to the cell and then goes on to cause disease. As science changes, our recommendations may change, but for now, the layered approach with masks and vaccines are the best we can do to help prevent this infection that can make our children sick. The Delta variant has some clinical differences we've seen. People now have not lost their smell as much as they did before with the original coronavirus we were facing. But the children are also seeing a lot more nasal secretions, and as you all know, that's a great way to spread disease. I'd like to conclude by talking about firemen. We send them into a building to fight a fire with a helmet, an aspirator, and a cape or a coat and shoes to protect them from a fire. It doesn't always work. Sometimes in their service they give their lives because the equipment wasn't enough and the fire was too strong. But we want to send our children into a fight with a good chance. So we do recommend masks, we do recommend vaccines, and we welcome your questions. Thank you.
Hi, my name is Stephanie Welch, and I'm the Executive Director of Quality and Infection Control at White River Health System. My purpose is to provide you with, if you were to implement a mask advisory policy, what the logistics of that would look like. So in just a moment, I'm going to share my screen with you, and I'm going to go over some of the data that we've decided to use. It's a super easy tool that can be utilized by anyone. You don't have to understand data or analytics or statistics to utilize this method. It's super easy and friendly. In addition, I did want to point out that on August the 5th, the CDC did make some really big, important updates on their guidance for schools. And those are some of the main reasons that I think that implementing this mask policy is just completely crucial. The first is that if 2 individuals, children, teachers, are within 3 to 6 feet of each other, and they're both wearing a mask correctly and consistently, if one of them ends up being positive, the other does not have to quarantine. So this could be huge in terms of keeping your school open and keeping your teachers there to be able to staff. Because if they're both wearing their masks, then the person is protected from the other person. Just based on logistics in general, keeping people in school and parents at work is, a beautiful thing for the economy and for all the people. But that's not even considering the fact of keeping the children safe or the teachers and staff safe. And we know that masks are a very non-invasive form of protection. And so I just wanted to iterate that main point to you. I will be going over some additional CDC updates in just a moment, but I wanted to start with that because I think that's a main point that we need to consider in this. Thank you. And I will move to sharing my screen. Okay, what you are seeing in front of you is the COVID-19 mask advisory policy. The intent of this policy is to provide guidance for your school district regarding the use of COVID-19 precautions based on the prevalence of COVID-19 within Independence County. Data to guide the parameters of this policy will be reviewed weekly by the administrative team, and they will utilize the covidactnow.org as its primary data source. And I will show you that in just a moment. I did put a disclaimer on there that this guideline is subject to adjustments based on guidelines received from the CDC. We never know when those guidelines may change, so I wanted to have that in there for you. Standard precautions. At all levels of risk, classrooms should continue to emphasize the use of barriers, physical distancing, and thorough disinfecting of all facilities. So what you see next is kind of what we're calling a little stoplight. Yellow is the low risk zone, and that is 0 to 10 daily new cases per 100,000. The per 100,000 is based on statistics, and it's the number of cases divided by the total population times 100,000. That makes it where we can compare ourselves to other cities regardless of the population size because it's using a standardized metric. So in the low risk, 0 to 10 daily new cases per 100,000, mask would be optional for both teachers and students regardless of vaccination status. In the medium risk, 11 to 25 daily new cases per 100,000, mask would be recommended for teachers and students regardless of their vaccination status. And in the high-risk zone, cases 26 to 100 or greater, mask would be required for both teachers and students regardless of vaccination. This does follow CDC guidelines stating that both vaccinated and unvaccinated in high-risk areas should be wearing masks. And so we did want to follow their recommendations. Mask, if you were in that high-risk zone, which we are currently, would be required to be used indoors, worn by individuals K through 12, including students, teachers, and visitors, regardless of vaccination status. This would include indoor physical education or recess. However, if they're doing rigorous exercise, that can be up to the instructor to determine if masks can be optional. This mask would be also required during transportation, so on your buses. But the main difference, though, is when you're outdoors, mask would not be required because you are outside. There's better ventilation and less risk. However, the CDC does recommend unvaccinated people should wear a mask outside if the activity involves staying in close contact with other people. Sports and other extracurricular activities for indoors participants, meaning the athletes or the musicians, would be required to wear the mask when they're not actively participating in the activity. Athletes or musicians not in play should wear the mask on the sidelines, on the bench, or in the classroom when they're not in competition. Coaches, teachers, and activity sponsors are required to wear masks. Spectators would also be required to wear a mask at all indoor spectating events. Outdoors, participants would be optional to wear a mask. Same with coaches, teachers, and activity sponsors, and spectators. So at all levels here, it would be optional. For mask selection, it's important that the mask would cover both the nose and the mouth and be well-fitting against the side of the face with no gaps. A 2-layered, washable, breathable fabric cloth mask is definitely recommended and approved. Surgical or medical grade mask, the blue ones you see a lot of, are very acceptable as well. They do need to be disposed of daily. Gaiters or neck gaiters, they're sometimes called, must be 2 layers, or you should be able to fold them to make 2 layers. A face shield on its own is not recommended. They're still doing studies to evaluate the effectiveness of this, but it is unknown at this time. I do know the importance of speech therapy for children, and so it could be used with a face shield for this instance during their sessions, or they could use a mask with a clear window or a plexiglass barrier. However, after the sessions, it's important that they put back on an approved mask outside of those sessions. So now that I've kind of talked about the mask specifics and what that stoplight chart looks like, I'm going to switch over now to the website that you would be using to identify which of these areas you're in. The website I'm going to type in again just so you can see what it looks like from the beginning is called covidactnow.org. This website is kept up to date daily. It is used with CDC data. It also is using Harvard Analytics. I have used it since the beginning of the pandemic in creating phase plans for the hospital system, and it's been a really, really great tool. This map that you're looking at right here are colors based on the number of vaccinated. You can see the lowest gray here is for places that are the least amount of vaccinated to the highest, and Arkansas is about 49% with a first dose. Next is the risk levels. You can see the darkest shade is the greatest risk. That's the severe zone. Arkansas, Louisiana, Mississippi, and Florida rank in there in the severe risk. So what you would do from here, you can click on Arkansas. This is going to give you an overall risk level for Arkansas as severe. This is based on daily new cases, infection rate, positive test rate, and the number vaccinated. You can also see over the past 30 days in the state of Arkansas, cases are increasing, hospitalizations are increasing, and deaths somewhat increasing, maybe a little bit downward trend there, so that's good. But over here on the right, you're able to click on any county. We'll click on Independence. And you can see our risk level is also severe. The same metrics as the state are provided here. And we're going to scroll down and look at, this is a graph that shows vaccinated first dose versus second dose. And then this is the main graph that you're going to work off of using that chart. So on that chart, when you were in the yellow zone, that was the low risk. You can see that here. That's whenever mask would be optional. Whenever you would hit that orange zone, that's whenever mask would be recommended. And then when you hit the red zone or even the dark maroon color zone, that's whenever mask will be required. The beauty of this is that it's not blanketing precautions based on areas where they may not be at risk. You know, if it's South Arkansas that has a huge incase and we're doing great, then let's take our mask off. Let's give ourselves a break and let's give the kids and staff and everyone some hope. But whenever cases are increasing, it's really important that we use every tool that we have. The CDC really speaks to a multi-level approach to this, and we know that the Delta variant is so contagious, but we really need to use every item we have to protect our students. And this is a very simple way that we can do that without having to do the precautions when we don't need them. I think that's a win for everybody. The way I would suggest using this is using a 14-day trend. So you're not going to make any adjustments unless it's been 14 days in that zone. That gives you the ability to not make changes and have to make changes again. It keeps you from saying, this week put your mask on and next week take it off. You can see that it's pretty consistent. Whenever you're staying in a zone, it's usually over a month or 4 months that it occurs. It's not rapidly going up and down, up and down, up and down. And so that's why we really want to look at 14 days in a zone before you would then decide to make a change. So for a good example of that, you could see, pretend this is now. As an administrator, you might be doing your weekly look and you say, okay, on July 9th, we hit the red zone. So let's see if we stay there for 14 days. Maybe the next week you're still there and you alert your decision makers and say, hey, just to let you know, we're 7 days into being in the high zone, and you're going to keep an eye on it. And then you look again, and it's been 14 days, and you see that you're still in the red zone. So then that would be the point that you would then pull your decision makers in and have a discussion of it's time that we require masks again. So I hope that makes sense with the 14 days that would be required to make that trend, and really gives you some flexibility and some guidance on when to use the precautions and when you can back off of them. So I'm going to filter back over here to that table. So again, that mask would only be required in that high-risk zone. And now I'm going to scroll down to, this is not part of the policy, but this is the additional CDC guidance that was just updated on August the 5th. I'm not going to go into every single point. I'll let you look over that on your own, and I'll make sure that you all receive this. But what I did want to point out is that they do, again, recommend a multi-level approach: vaccinations, masking, screening, testing. One of the things for the screening, testing, I think it would be great if the state could provide those for the school districts, and I know they haven't yet, but we do plan at the hospital to advocate that y'all are given test kits, because it would be a super easy tool to utilize. They're self-administrative. If you've done the Buy Next Now test from Walmart or Walgreens, you can see that those take 20 seconds to complete, and they're super easy. The person can do it for themselves. It's just a nasal swab. So anyway, this is just some recommendations they make on screening, testing, if you did have those available. They did provide on the CDC website some funding that's available to obtain these as well, if you're interested. And then I'll also let you on your own time look at the screening, testing recommendations for the school. It basically states that, in these high-risk items, unvaccinated people would benefit from that screening testing. Next, I will move to the other main update they've done recently. Fully vaccinated people who have a known exposure to someone with COVID, they should actually be tested on days 3 to 5 after the exposure, regardless of whether they have symptoms. This is a change. They were saying that if you were fully vaccinated and you were exposed, you didn't have to worry about testing, but because the Delta virus is so contagious, they are recommending you go ahead and test on days 3 through 5. However, during that time, you don't have to quarantine. As long as you don't test positive on days 3 through 5, or you don't begin to have symptoms, you can still continue to report to work or report to school. And then this next part is what I talked about in my intro video, and that is that with contact tracing. In the K through 12 indoor classroom setting, the close contact definition excludes students who were within 3 to 6 feet of an infected student if both the infected student and the exposed students correctly and consistently wore well-fitting masks the entire time. So once again, if our students are wearing a mask and they're exposed to someone, their peer that's sitting next to them, they're not going to be considered exposed as long as they're wearing their mask. That's going to keep them safe, and it's going to keep them from having to be out of school, and their parents from having to miss work, and your staff from being absent and having to fill their spot. It also goes on to state, again, the fully vaccinated don't require quarantine, but they do need to be tested on days 3 through 5 and monitor for symptoms. Not vaccinated, they need to quarantine for 14 days if they do not test. If they do a test on days 5 through 7, if they are negative, they can return on day 8. And then it goes on just to state that we should still continue to limit non-essential visitors, volunteers, and activities involving external groups, and that we should still maximize spaces for eating meals, and that staff should be wearing masks at all times during meal prep. So in closing, I want to thank you once again for allowing me this opportunity to speak with you. I hope that you found this information valuable. If you have any questions at all, please don't hesitate to contact us. We will be happy to troubleshoot any of those with you. We'll be happy to adapt this to make it your own and to fit your school system. Most of all, our goal is to keep people safe, to keep people healthy, to keep people out of the hospital, to keep people in school, and to get us all back to normal. We know that masks can help do this. So we just urge you, please, really consider this, and please reach out to us if we can help you in any way. Thank you.